This is the third and last voice-over PowerPoint concerning this section. We have already done the parenteral anticoagulants, then we did the direct oral anticoagulants, the DOACs, and now we move on to the classic oral anticoagulant, and that is vitamin K antagonist, warfarin, that we talked about many times before. A little bit of history. In the 1920s, people have observed that chicken who were fed low-fat diet were really bleeding. And then it turned out that because they were fed a low-fat diet, that diet was missing in vitamin K, and that vitamin K was important for coagulation. And actually, vitamin K is a coagulation vitamin. Another thing that was observed is that cows were dying of severe bleed after eating decaying sweet clover, and it turns out that the chemical compound that was causing this bleed was coumarin. So then they discovered coumarin as an anticoagulant, and in the 1940s it was used as an extremely effective rodenticide. And even until those times, we still use it as a rodenticide. Why is it interesting? Well, rats are quite clever animals. So if they see food or something, before they all go and eat, what they do, they send a scout. They usually choose the oldest or the sickest. And that scout goes and tries and eats the food, and they wait. If nothing happens to that scout, so the rats would go and eat. But in the case of coumarins, nothing will happen to the scout right away. What will happen is that this rat will run around, hit its head or something like that, bleed to death. So the rats would not really be able to associate the death of that rat to the food. And this is why it's a very effective rodenticide. We really fool the rats. Only later were coumarins used in the clinic, and the fear really is bleeding. So how do these work? Well, it's very simple. They are vitamin K antagonists because their structure is very similar to vitamin K. And you see here warfarin, and you see acenocumarol. In Lebanon, actually, we have acenocumarol, but also it's a coumarin, it's a vitamin K antagonist. The trade name is Syndrome. How do those work? Let us review a little bit the vitamin K cycle and why is it important in the coagulation pathway, and then we'll understand how warfarin and the other coumarins work. Well, what we have is reduced vitamin K. This reduced vitamin K is very important to activate non-functional prozymogens into functional zymogen. It is actually a cofactor for the enzyme alpha-gamma glutamyl carboxylase. And then after that, we get oxidized vitamin K, and we really need to replete reduced vitamin K. How do we get reduced vitamin K again? We get that through the vitamin K ORC enzyme. So we know this by now. Now, what is the relation with the coagulation cascade? Well, remember the factors that we talk about, factor 2, factor 7, whatever, those are zymogens. But before they become functional zymogens, they are prozymogens and they need to be activated. Why is that? Because we have in some of the factors, not all of them, we have non-carboxylated amino terminal glutamate residues, and with the gamma carboxylation, we end up with those GLA residues, and those GLA residues make the prozymogen functional zymogens. This is showing the GLA residues in one of the factors that need that, and the factors really here that we're talking about are factors 2, 7, 9, 10, and protein C. Why are those GLA residues important? Very simply because they are capable of binding calcium and interacting with the anionic phospholipid surface. Remember in the very beginning when we discussed the cascade, I told you please be careful. We really need calcium and we really need to interact with the phospholipid surfaces. And how is this happening? It's really happening with those factors specifically through the GLA residues as shown on the figure on the right. It's also important to note that those GLA residues are not only in the coagulation factors. By the way, protein C is definitely not a coagulation factor. It's actually in anticoagulants. Well, also those GLA residues, you can see them in other proteins such as the bone matrix, the pancreas, lung, and others. So now is the time for us to discuss the mechanism of action of warfarin. We get this figure again. Warfarin really again looks like vitamin K. So it is an antagonist of the VKORC enzyme. Basically, when we have warfarin in the system, it competes with the oxidized vitamin K on the enzyme, and hence we do not reduce vitamin K. We don't have reduced vitamin K, and hence we do not have a cofactor for gamma glutamyl carboxylase. We have talked about this enzyme before potentially being polymorphic and hence leading to affecting the susceptibility of the enzyme. And we also talked before about warfarin being metabolized by CYP2C9 and what that could lead to. Again, I highly recommend that you watch this video. It's a beautiful explanation of the whole process. Now is the time to ask ourselves, okay, what test do we want to do to monitor the effect of warfarin? Remember, we said that the DOACs are really nice, but we cannot monitor for them, right? Whereas for warfarin, although we have some inter-individual variability in the response, for example, if the patient has a polymorphism, also we'll see later there is a potential for a lot of drug-drug interaction, but despite that, we can monitor. Okay, how do we monitor? We already discussed before that for the anticoagulants such as heparin and low molecular weight heparin, not really low molecular weight heparin, for heparin we monitor with APTT for the intrinsic pathway. Well, it turns out that for warfarin we monitor with the extrinsic pathway. Let's remember what are the factors that are involved here. 2, 7, 9, and 10, and protein C, right? So you would ask yourself, okay, 2 is common, 10 is common, but 7 is extrinsic and 9 is intrinsic. So why are we really measuring with PT-INR for the extrinsic? Well, the reason is shown in this slide, simply because factor 7 has the shorter half-life of 6 hours when compared to factor 9, and hence the first thing that would be affected is the extrinsic pathway. Ultimately, the intrinsic will be affected as well, but how do we really monitor? We monitor with PT-INR because of factor 7. Warfarin will need some time to work. It's not like low molecular weight heparin or unfractionated heparin that would activate antithrombin 3 and that would inhibit thrombin and factor 10A right away. Here, what we are affecting really is the activation of the prozymogen into zymogen, but we already have zymogens in the circulation, right? So the effect will not show right away. The effect will show when the already available active zymogens in the circulation are removed by the reticular endothelial system and there is no more zymogen, then this is when the effect will show. And hence this is why you see the plasma concentration of warfarin would be high, yet the effect will need some time to show. And this is something that you will hear in the clinic, something that we call bridging therapy. For example, suppose you have a patient now and you need to anticoagulate that patient. If you need the effect to happen right away, you start with heparin, for example, but you may start warfarin, and in 2 days, hopefully, you may stop heparin and continue warfarin because warfarin would have picked up. How do you know if it has picked up or not? Very simple. You do the test, PT-INR. If it is within the target that you need, then you're good. In this table, we summarize the characteristics of unfractionated heparin versus warfarin. Now we know the mechanism of action, we know the route, the onset, we explained it. Also, something I didn't mention is concerning the duration. An advantage of warfarin is that once it's picked up, it actually has a long half-life, so it's actually given once a day. We talked about the monitoring, The nice thing about warfarin is that there is an antidote that is readily available. What is the antidote? Simply reduced vitamin K. Therapeutic uses, this is an anticoagulant we discussed, can be given in MI. Atrial fibrillation, I have it in green because this is a chronic condition, chronic atrial fibrillation, and the patient would be at a risk of thrombus. You need to anticoagulate for a long time. And in this case, you really need an oral anticoagulant that the patient can take rather than something, an injection. Now we're happy that we have the DOACs that can also be given chronically. However, warfarin is again cheaper, and also warfarin can be given if the patient has valvular heart disease. We agree that the DOACs, at least then there isn't as much evidence for the DOACs as much as for the warfarin. It can also be used for other indications. And please note that these change with time. So one has to be updated on all of those. Adverse effects, bleeding, of course. We agreed that bleeding is a side effect of all of those drugs, and we also, similarly like the others, this can be problematic in places where we may have compression of vital structures such as the spinal cord, the renal papillae. Treatment is the antidote, vitamin K, or you can also give fresh frozen plasma, of course, with the active zymogen. Another thing that could happen, remember that here we're also affecting protein C. So in patients who have partial protein C deficiency are prone to skin necrosis, and they could have skin necrosis in the extremities, adipose tissue, penis, and breast, and those are really, really painful. 2, it crosses the placenta. It's small, it crosses the placenta. Warfarin is absolutely contraindicated in pregnant women. It's also detectable in milk, so we don't want to, probably we don't want to lactate if we're taking warfarin. What could happen? We could have an epiphyseal calcification, chondroplasia puncta in the newborn of mothers of Coumarin. Also, it may affect growth. Absolutely contraindicated. And here are examples of drug interactions. If a patient is taking a drug that promotes bleeding, you would have more bleeding. If we have drugs that increase the anticoagulant effect, such as, again, displacement from albumin, hepatic enzyme inhibition, or drugs that decrease the anticoagulant effect. So we really have to be careful about that. Who are those patients? Patients with atrial fibrillation most probably are taking many other drugs, so one has to be vigilant and monitor. So we reached the final stage, and that is the fibrinolytic drugs. What are the drugs? Those are plasminogen activators, and we have streptokinase and recombinant TPA. Again, I highly recommend that you watch this very short movie. It explains how physiologically we have TPA that activates plasmin into plasminogen, and how TPA is controlled so that we don't have overactivity, and how the process is also controlled so that the fibrinolysis happens at the clot, and so that we don't have erratic lysis anywhere else. So please do watch this one. To summarize what's happening, when it's time for the clot to lyse, we want to cut the fibrin, and in order for that to happen, we need plasmin, and plasmin needs to be activated from plasminogen. And how does this happen? This happens through the enzyme TPA. Again, for TPA not to be working wildly, we have in the circulation PAI1 and 2 that inhibit TPA. So what are the fibrinolytic drugs? They are really TPA, basically providing high doses of TPA so that we activate plasminogen into plasmin and lyse the clot. These agents are available to remove already formed thrombi. Indications, you can guess, MI, massive embolism. The oldest and first prototype of those drugs is streptokinase. This is actually taken from beta hemolytic strep. It's a natural protein. Now it's rarely used clinically because we have better drugs that are based on the recombinant DNA technology. And also the newer drugs are more fibrin specific. What is the problem with that? The problem with streptokinase is that in addition to fibrin, the streptokinase plasmin complex may degrade other clotting factors. So we have an additional risk of bleeding, and it also degrades fibrinogen. So it's not as specific as the newer agents. Adverse effects, you would expect bleeding, of course, because it's a natural protein. We may have antibody production, start from itching all the way to anaphylaxis. Some patients may develop hypotension, and this is the case, you want to give the IV at a slower rate. If the patient develops fever, you want to give acetaminophen and not aspirin, because that would lead to a higher risk of bleeding. For the recombinant DNA technology, we have alteplase, and we also have some variants of alteplase, and that is retiplase and tenecteplase, that have a longer half-life, and hence it is easier to provide them in the emergency room, and they are also relatively resistant to inhibition by PAI1. Of course, we have bleeding with those drugs. One thing that could happen is clot dissolution. So we may have lysis of fibrin in physiologic thrombi, and not only the one that we're worried about. So previous or recent vascular injury is problematic in this case, because the thrombus could be dissolved. Also, we may have a systemic lytic stage, and that usually happens with streptokinase much more than the others, and because streptokinase is not very much fibrin specific. Now, to tell which one is more toxic is really hard. The nice thing about it is that we do have antidotes for those drugs, just in case we have excessive bleeding. Again, when we want to start giving those drugs for a patient who presents to the emergency room, for example, we want to be aware of the absolute contraindications and the relative contraindications. Does the patient have any prior intracranial hemorrhage? Does the patient have a cerebral vascular lesion that could bleed? Does the patient have a malignant intracranial neoplasm? You really don't want the patient to bleed in the brain. Does the patient have an ischemic stroke within the last 3 months? Now, if it is within the last 6 months, then this is a relative contraindication. Is the patient actually bleeding? Is the patient bleeding? Not really menses, but coming with active bleeding. Suspected aortic dissection, we talked about that before, and any significant closed head trauma or facial trauma within 3 months. Relative contraindications: uncontrolled hypertension, pregnancy because you may lose the baby, stroke within 6 months, major surgery, trauma, prolonged CPR, non-compressible vascular punctures, active peptic ulcer, internal bleed, use of warfarin. For streptokinase, prior exposure could be problematic because you would be at a higher risk of developing allergy. We're almost done. In this table, I summarize for you what we have discussed, the drugs that we've discussed, the mechanism of action, and their main therapeutic effect. And finally, this slide is old. It's coming from the medical letter in 2011. This is not for your memory at all, but it just puts the drugs in perspective and also what are the indication of each drug. Of course, this changes, but just to have a general picture.